challenges that knowledge exists about effective health services for older adults that could optimize patient-resident outcomes if implemented properly. Yet we have organizations like the Cochrane Collaboration that supplies us systematic reviews, and the number of systematic reviews in the topic of care of seniors continues to increase. But the question is, how do we move that information into the care process? Next issue or challenge is that the need for greater competency of organization leaders in change management. And we have a big issue with high turnover of leaders in long-term care homes and in community care, and this causes more challenges for us to ensure the knowledge exchange process is operating properly. And then developing more knowledgeable healthcare practitioners, care providers, decision makers, policymakers, and researchers. Quality of care can be improved, but we have very rare kinds of provincial activities like this, and we're working with Health Quality Ontario. Sorry, don't tell me this thing probably goes ahead by itself. But anyway, the Residents First project is a 4-year project that's been going on, and it has touched about over 500 homes, but only about 130 or so have actually moved forward with many of the things that have been introduced, and the program's coming to an end. So the discussion we just heard about Interact would be an interesting one to have Health Quality Ontario, for example, take on as the next project. But there's much to do in this area. There's a failure in translating research into practice and policy across the health sector. Another big issue that the LHINs are looking at now is palliative and end-of-life care, and how do we start to recognize that long-term care homes are a major place where this is required, and introducing greater competence in this area. Mary Lou Kelly's here today and was here yesterday, and she's talked about this. And then finally, understanding how to ensure system-wide implementation to bring this into routine practice and policy is imperfect. And we have major challenges, a very large system, 620 homes, over 800 community care agencies, and 158 hospitals with emergency rooms. So we have a big challenge, and so where do we go next? And so there are multiple theories about knowledge exchange and translation of information and both tacit and formal knowledge or empirical knowledge into practice. But we have the problem of deciding which theory to use and how to do this. And I guess my take-home message today is pick a theory that seems to fit the issue that you're thinking about and apply that. And so the next slide shows just a short list of 19 theories that you can choose from. And you can't read them all. I wasn't going to worry about that too much, but I think the slides for the presentation, Paula Neves is super in getting all these on the internet for OLTCA, so I think you'll be able to access this information after. The one that we've used with the Seniors Health Knowledge Network, I'll just mention that one, is number 5, the parish model, promoting action on research, implementation, and health services. And this is a result of work they've done after a major literature review on these models, and concluded that there were 3 things that drive change: the accumulation of the evidence and putting it in a form that people can digest and use on the front lines and in policy. The second leg of the stool is a 3-legged stool. The second is facilitation. You need to help get the information that's known, both experiential and empirical, into the decision-making process. And we have people like knowledge brokers now that are one of the key ways in which we facilitate. But probably the third leg of the stool is the most important in many circumstances, and that's what Kitson and Rycroft call the context. And other people like the health services implementation, or whatever Steve's new name is for his organization, they've always talked about this as receptor organizations, organizations that are ready to use the new knowledge. Another way to think about it is it'd be interesting if every board, every senior management in large organizations and even small organizations had not only a VP of finance, but also a VP of knowledge. Or when you think about it, if you get up in the morning and you're a nurse and you leave your knowledge at home, what can you do? So knowledge exchange and management is really, really important. But this three-legged stool is the way we've thought about conceptualizing the way our Seniors Health Knowledge Network would work, and also the way we'd evaluate it. But I won't go into that in any great detail. We have an article in Health Management Forum about the network where we talk about this a bit, and we also have some articles in Implementation Science, which is the new journal in this field that has become kind of the, I guess it's kind of the gold standard journal for people who are doing research on how to do this process of knowledge exchange and translation. So we have in our Ministry of Health and Long-Term Care, I think she's part of the seniors strategy team within the ministry, Deborah Sattler. And I've got a couple of slides of hers that are kind of interesting. Again, I don't have time to go through this in detail, but she takes the view that a traditional way of thinking about this is you'd plan, you'd implement, and then you look at the impact. And there are some, attractiveness to this. It's simple, and it's the traditional way, but it does kind of gloss over the complexity of this process. And for example, there are different sectors. There's policy level, organizational level, and clinical issues. There's, like I mentioned, the context that you're doing it in, and also the implementation process itself is not straightforward. Then there's Sharon Strauss at St. Michael's Hospital, who is the sort of guru geriatrician, our mage geriatrician in Ontario that does research on this field, in this field. And St. Mike's has the Lekashing Institute, and they have a number of groups, if you go on their website, that are interested in knowledge to action issues. And this is also kind of a modification of Ian Graham, who was with the Canadian Institute for Health Research. His model, and Sharon has changed this a bit, but it's essentially inquiry, synthesis, and producing tools in the middle, which is what the Cochrane collaboration attempts to do, but kind of weak on the bottom one, knowledge, tools, and products that are digestible, especially for personal support workers. But in the Seniors Health Knowledge Network, we've produced things like the best practice blogs that Mary Lou Vanderhorst has produced, for example, in particular in oral health care, which I'd recommend to you. The other thing about this that's a bit glossing over the complexities too is it looks like there's this sort of linear process around the outside, around here, which it looks really good, but of course you can start anywhere on that cycle. And from a management point of view, it's a question of where do you start and how do you ramp up your organization to be able to engage in this process or this cycle. And then Deborah Sattler recommends we think about things this way, though.